Adjacent segment disease is a big issue in spine surgery. Now, what this refers to is when somebody starts to have a problem at the segment above a previous fusion. So, for example, somebody may have a fusion from L3 to L5, so that's 2 levels, and then they find out that, maybe a couple years later, that L2-3 is now having a problem, and they're now getting nerve pinching at L2-3, which is causing leg pain. Adjacent segment disease, we believe, is likely a combination of a few things. One of them is just that when somebody has spine disease, it affects the whole spine. Unless there was a very acute traumatic issue with one segment, when somebody has degenerative spine disease, it means that there is some level of degeneration starting in other parts of the spine. Even though when somebody first sees me, the L4-5 level may be the problem, and we address that, L3-4 may be on its way to having a problem as well, regardless of what we do at L4-5. So the natural history of the spinal segments is a big issue and just probably the primary contributor to adjacent segment disease. The other big question about adjacent segment disease is how much does fusion at one part of the spine affect fusion at other parts of the spine? With a one-level surgery, the incidence of having adjacent segment disease, and what I think is sort of the best literature on this topic, shows that about 16% of patients will have symptomatic adjacent segment disease within the first 4 years after surgery. That means 85% don't, so it's still pretty good odds. But one thing about a fusion, or when a fusion is done, one thing that we're learning more and more about is that establishing the natural anatomical alignment of that segment is extremely important, because patients in which that natural anatomic alignment is not established, so for example, the curvature of that spinal segment, when it's fused together, that should be reestablished. It's really bad to fuse somebody, even at 1 or 2 levels, in a very unnatural flat position. We believe that that is a very big contributor to what we call adjacent segment disease. And it's very important that if you're thinking about undergoing a revision spine surgery for adjacent segment disease, that your surgeon is considering the position of the prior fusion. I'm going to show you a very classic example of something that I see pretty often in my practice. So this here patient is a 72-year-old female, and she came to me with leg pain and progressive back pain. Now, she had had a fusion from the sacrum to what I'm going to call L3 about 5 years before this. And, initially she was doing well, her leg pain got better, but over time it became harder and harder for her to stand upright. Now, this is an X-ray from 2019. She had her surgery in 2024, or the one that we did was 2024. So this is from 2019. And we can see that if we look right here at the L2-3 segment, there's no disc. This L2 and L3 segment are almost touching each other. This black right here is actually a vacuum. That means there's nothing there. And now when I see her in 2024, that disc is even worse, right? Now we have bone spurs growing. It looks like these screws are actually starting to come into the disc space. So basically, this adjacent segment right here, her adjacent segment disease, is getting even worse. And when we looked at her MRI, we can see that here is the spinal cord, and here are the nerve roots coming down the spinal canal. We can see that she's getting pinching right here at this L2-3 level. So she has adjacent segment disease in the form of disc degeneration, also in the form of central stenosis. So when she came to me with back pain and with leg pain going down the legs, it fit very well with what I saw in the imaging. The thing about her, though, is that when we take a 1,000-foot view, just by looking at this X-ray, you don't have to be a spine surgeon to see that how she's standing is somewhat unnatural. And this is because she is standing with what we call a flat back. So she is lacking this natural curvature that's needed in the bottom of the spine. And that is a big contributor to having adjacent segment disease. So when we spoke and I talked with her, I said, look, You could do a surgery to just deal with L2-3. You could extend the fusion, which would take care of the stenosis, but I don't think that's going to help with your posture. And I think that if we do that, you have a very high chance that the level above is going to break down as well. So when we talked, I thought the best thing for her was to address the adjacent segment disease, but also address the spinal alignment in the bottom, meaning reconstitute her natural spinal lordosis, the natural lumbar lordosis, in order to, in a way, help protect those segments above from continuing to go down that same road. So what we did for her was something called a PSO, or a pedicle subtraction osteotomy. And what this is where we cut a wedge of bone through the prior fusion mass, and then we actually extended her fusion up that one level to L2-3. So she's about 2 years out now. She's doing well. I think that we've hopefully slowed the progression of the adjacent segment disease, though I am a little worried that this L1-2 segment is going to be next. I think hopefully we got her in, as good a position as she can be in right now, and she's feeling good. So as long as she's feeling good, we'll just continue to watch it for now.